Good. Well, without further ado, caring for patients with genitourinary malignancies, and Dr. Rose will start off with your presentation.
Great, thank you. And again, thanks very much for having us. We're excited to give this lecture in advance. So the objectives of this talk, between both mine and the next talk, is really to understand the breadth of what genitourinary or GU malignancies are, specifically to recognize the role of each of our multidisciplinary team members, because we are a great example of really how a multidisciplinary team works, and works well, I think. We're going to learn the basics of each major type of GU cancer, and those would be prostate, bladder, kidney, and testis, and then walk through different types of cancer treatments used in GU malignancies. So this is the genitourinary tract. This is clearly a male, and you can see kind of we treat all the cancers that are really pictured here. So from the top, you know, cancers that start in the kidney, cancers the ureter runs down from the kidney into the bladder, and you know, cancers can develop in the ureter, in the bladder, along the urethra, in the penis, in the testis, behind the penis, in the prostate, along the urethra. And we really treat any of those. And, you know, some are more rare than others, but we run the gamut of different cancers. Next. And so, you know, we know that cancer, this slide now needs to be updated in the COVID world because it's from a couple years ago, but the top two causes of death in the US have not changed, and cancer is really riding a very close second to heart disease with, you know, I think it's over 600,000 cases per year of death, so it's a huge problem still. Next. And you can see that GU cancers really play a prominent role in this, so especially in men. So, you know, prostate cancer, bladder cancer, and kidney cancer is more common in men than women. And you can see that prostate cancer is the most common malignancy in men, and kidney cancer, you know, makes the top 10 in women as well. Okay, next slide. And similarly, if you look at actual deaths and not just cases, you know, prostate cancer is the #3 leading killer of men in terms of cancer in the United States, and bladder cancer similarly makes the top 10. None of them rank for women, although, you know, we still see plenty of these cancers in women. Next. So the most common GU cancers are really prostate, bladder, kidney, and then testicular cancer, which is a lot less common, but because it affects young men, can be a cancer where we really have an opportunity to make a difference. Next. So this is a picture of most of the members of our team, and I really put this up here to highlight how many different people it takes to take care of these patients. And so you can see I'm in the very upper left there, but we have a team of medical oncologists, of which I am one, you know, quote, the chemotherapy doctors. The pharmacists, you know, sit in clinic with us and are integral to the management of our patients on treatment, but we also have our phenomenal coordinator team, our nursing team, the urologic oncologists, those are the surgeons on the team, the pathologists who help us with diagnoses, a huge team of research staff, that's about 1/3 of the staff, our radiologists who help us with scans and biopsies, the radiation oncologists who give radiation, our medical assistants who make the clinic run, and our nurse practitioners as well, who help us, you know, see patients and manage everything. And, you know, without every single one of these team members, we would not nearly be able to keep, you know, keep good care of these patients. Next. And so I'm just going to go through each of the different cancers one by one and talk about the very basics of it and how kind of each team member really helps to take care of these patients. And so prostate cancer, you know, which is the most common cancer in men, is a disease in which malignant or cancer cells form in the prostate gland, which essentially surrounds the urethra at the outlet of the bladder. Next. So, you know, the prostate is partially glandular, partially muscular. It sits in the lower pelvis, and it's essentially an accessory reproductive gland. It makes this alkaline fluid that forms part of the ejaculate, and then that helps with motility and nourishment of sperm. And there's several zones of the prostate where you can get cancer in any of them, and some are easier to detect than others. And the prostate tends to be small in young men, about the size of a walnut, but grows with age. Next. So most prostate cancers are what we call adenocarcinomas, meaning they form from the gland cells of the prostate. Over 90% are, and they act a certain way. Some other cancers in other parts of the body are adenocarcinomas as well, but predominantly prostate cancer is adenocarcinoma. There's a few others that form from the neuroendocrine cells, or they transform to neuroendocrine cells, but those are the minority. And prostate cancer has a pretty predictable way that it spreads. So first it goes to the lymph nodes in the pelvis, and then distant spread is most commonly to bone, to other lymph nodes, and less commonly to the organs, places like lung or liver. And if you have a person that has prostate cancer that's spread to some of those organs, that's typically a bad sign. And the way that we diagnose the prostate cancer is, it gets picked up either by a digital rectal exam with someone's primary care doctor or urologist, or an elevated blood test called a PSA. Next. So, typically prostate cancer is not symptomatic. Occasionally you can see what we call lower urinary tract symptoms, or LUTS for short, which is essentially urinary problems, urinary retention, difficulty urinating, difficulty with getting or maintaining your stream of urine. Once the cancer has spread, sometimes it can cause bone pain, renal failure, or even spinal cord compression if it spreads to the bones in your spine and that presses on the spinal cord. Next. And so to diagnose prostate cancer, this is a picture of an actual biopsy of the prostate. So, there's a lot of debate even today as to whether or not we should be screening all people for prostate cancer. And we currently use a shared decision-making model in which patients typically talk to their primary care doctor or their urologist about whether or not to screen for it. And then if they decide to, we send this blood test called the PSA or do a digital rectal exam. And if anything is detected either on the rectal exam or by an elevated PSA, they will typically get a prostate biopsy, which is done in the office, and they put an ultrasound probe in the rectum along with a biopsy needle and take a bunch of different spots of biopsies. Sometimes we now do this under other guidance of an MRI instead, but this is the typical way that we diagnose the cancer. Next. And so once we do that, we have a specimen of the cancer, and we can look at it under the microscope to look at sort of how much does it resemble the normal prostate. And we call that the tumor grade, essentially a measure of the microscopic appearance of the tumor and how aggressive it looks. And in prostate cancer, there's 5 different grades. They range from 1, which looks just like normal prostate, to 5, which is hardly recognizable as prostate even. And we look for what's called the dominant histology and then the secondary histology, and the pathologist assigns 2 different numbers, and then you add them up, and that's called a Gleason score. And so the Gleason scores for cancer range from 6 to 10, and the more aggressive cancers are, Gleasons of 8, 9, and 10. Next. Staging, however, is looking at how much tumor is in the body, essentially the extent of disease in your body, and that helps determine treatment, prognosis, and surveillance needs after treatment. And so this is a common currency for how we report treatment results. People with X stage do X well, and people with X stage or Y stage do Y well. Go ahead, next. And so this is a chart. Every different cancer has a chart that looks something like that, that essentially groups clinical characteristics together to come up with an overall stage group. And so this is called TNM staging, but in prostate cancer, we also tend to incorporate the PSA, so that's the blood test that can detect or monitor prostate cancer, and then the Gleason score, which is essentially the grade of the cancer, how aggressive it looks under the microscope. And you put together sort of the clinical exam, the radiologic findings, so the extent of the tumor, so that's really stage, which is T, N, and M. So T is the size of the primary, the tumor that's in the prostate itself, which we call a primary. N is whether there's any lymph nodes involved, and M stands for metastases and whether there's distant spread. And so we look at that, which is called stage. We look at PSA, which is a blood test, and then Gleason score, which is grade, and then that helps us group it into different prostate cancer overall stages. Next. So treatment, and this is principles of treatment for pretty much any cancer, we call local, if we are just treating the cancer where it is. And the ways that we do that are typically with surgery or radiation. Similarly, local regional, so treating both the tumor but also some of the region around it, like the lymph nodes that it may have spread to, versus distant or systemic treatment, which is really things like chemotherapy, but also in this day and age, things like immunotherapy and hormonal therapy, which we will get into later. But really, we kind of divide cancers into whether we can handle it where it is with things like surgery or radiation, or whether we need to really treat the whole body because there's cancer that's either detected or suspected in the whole body. And commonly, we really combine these approaches. And so that gets back to that first slide of all those different phases. You know, it is not uncommon that we will have a cancer that actually gets surgery, radiation, and chemotherapy, or 2 out of the 3. And so it is very common that at least, 2 or 3 different teams of providers will see these patients with all of their support needed for each of the different treatments. And so you really end up having many people on your care team when you have a genitourinary malignancy. Next. So the options for prostate cancer treatment really depend on where you fall in that staging and your risk. So one option is called active surveillance. Essentially, it means that we just watch you closely. And there are some tumors, like those with a low PSA or a Gleason grade of 6, that we can safely watch. And these men are likely to die of something else. And so treating their cancer will likely just cause more side effects than actual benefit. And so we are doing this more and more. And it's not appropriate for everyone. Some people with more aggressive cancers or other reasons to have treatment, we recommend treatment. But, a lot of our either older patients or those with cancers that we think are really never going to cause a problem for them, we recommend active surveillance. Next. The probably original and one of the standard treatments is called a radical prostatectomy. So essentially surgery. You surgically remove the prostate gland and the seminal vesicles around it. There's lots of different ways to do the surgery. Sometimes you can do it laparoscopically or using little ports, and even robots are doing the surgery these days. It's a pretty easy surgery in the world of GU cancer. You just spend one night in the hospital, you leave with a catheter, and most people do really well, and then they just go on follow-up. Next. The kind of alternative to surgery is radiation, and there's several different types of radiation. The most common is what we call IMRT, or intensity modulated radiation therapy, essentially giving a high dose to the prostate and less dose to the surrounding tissues. And we use a machine that's outside the body and shoots radiation into the prostate. Usually takes 4 to 6 weeks, coming every day, Monday through Friday, and sometimes we give it in combination with some hormone shots. Next. There's other types of radiation. One is called brachytherapy, where we actually put radioactive seeds into the prostate, and then those emit the radiation to the prostate themselves. Next. And then there's some other treatments we use less commonly, but you can actually do either surgical freezing of the prostate, which is called cryotherapy, or heat treatment, which is called HIFU, or high intensity focused ultrasound. And sometimes we use those for patients that can't either get surgery or radiation or have some recurrence if they've already had those things. Next. And then there's advanced prostate cancer. And so this is most of what I do, but once a prostate cancer has spread outside a field of radiation or to a place that we can't just cut it out, it's typically a stage 4 metastatic cancer, and that is not a cancer that we know how to cure. And so treatment really shifts from trying to cure the cancer to prolonging as good a life as possible, and that is a lot of what I do. We call that palliative treatment. And in prostate cancer in particular, we tend to work on hormones because it's a very hormonally driven cancer. And so the cornerstone of treatment is really blocking the tumor's access to the male hormone testosterone, which we will talk more in depth about later. Sometimes we also use kind of standard chemotherapy. Next. So next, shifting gears to bladder cancer. So this is another really common cancer, more common in men than women, typically diagnosed later in life. The median age is in the 70s. And it's really a global disease. It's very common in places like China, even in the Middle East. And some of that is dependent on risk factors, which we can talk about. Most cases of bladder cancer are what we call non-muscle invasive, which I'll explain in just a minute. But most cases are handled only by a urologist. And then but this is the cancer that has the highest recurrence rate of any cancers that we see, and it's a very expensive cancer to treat. It's a substantial burden of health services and requires a huge team effort once the cancer has gotten to a certain stage. Compared to the actual burden and the cost that we spend as a nation on this cancer, we have comparatively poor research funding. And it's really just in the last 5 years or so that we've really made some great strides on treatment of advanced disease. Next. So these are the risk factors. So male sex, which I mentioned. Smoking is the biggest risk factor. Smoking does not just cause lung cancer. Bladder cancer is a huge smoking-related cancer, and smoking cessation helps. It decreases the risk of contracting a bladder cancer. Family history or other family genetic mutations can contribute. Age, as people get older, they're more likely to get bladder cancer. Chemical exposures, and this is why it sort of varies by geographic area. But lots of dyes, some of the chemos we use, textile workers, painters, and things are more likely to get bladder cancer. Prior radiation to the pelvis, or prior catheters, or things that make chronic inflammation in the bladder. One called schistosomiasis, which is an infection that's prevalent in some parts of the world that make bladder cancer more common. Next. And so this is the staging of bladder cancer. So it looks at the extent of the primary tumor. So that's what's called the T stage. And you can see the layers of the bladder wall here in the picture where, CIS, TA, and T1 cancers stick to the superficial layers of the bladder. And those are the cancers that really just meet with the urologist and get it cut out. Sometimes some chemotherapy in the bladder. And then once it gets to that muscle layer, those cancers are more likely to spread to other parts of the body. Those are T2 or T3 cancers. And like I said, about 75% are superficial cancers and about 25% are muscle-invasive cancers at presentation. Next. And so in these non-muscle invasive cancers, so that's the part in the red box, typically the urologist does what's called a cystoscopy. So they put a camera in the bladder, which is called, so through their urethra, which is called transurethral, and cut them out. So they also sometimes use something called BCG, which is you've probably heard of because it's also the TB vaccine, but it's essentially an immunotherapy. So it stimulates your immune system to get revved up and potentially attack a cancer that it's never attacked before. It's one of the original immunotherapies. We use a lot of different ones now. And we're starting to learn that we may be able to use some of our intravenous therapies that we use in later stage disease for some of these cancers as well. Next. And then muscle invasive bladder cancer is really what I see. And this is a classic cancer that really needs a multidisciplinary approach. And that's because we use all three types of treatment: chemotherapy, surgery, and radiation therapy in some cases. And so most typically we treat with chemotherapy followed by cystectomy or removal of the bladder, or we do a transurethral resection, so the urologist goes in with the camera and cuts out what they can, and then we give both chemotherapy and radiation. And so in that case, all three radiation oncology teams, surgery teams, and medical oncology teams are involved in the patient's care. Next. And then these are the different surgeries that you can have, which are always really interesting to see. The most common one we do on the left, which is essentially we take out the person's bladder and then we take a little piece of their ileum, which is part of their intestine, and we borrow it and we sew the intestine back together, and then we use that piece of intestine to carry the urine from the ureters, so from the ends of the kidneys, to the skin, and then create this stoma. And then the person has to wear a bag, essentially, that collects the urine on the surface of their skin. There's a couple other different ways you can actually create a new bladder out of intestine, and you can actually, you can actually kind of catheterize it every few hours. So instead of collecting urine in a bag, you essentially close the hole a little bit more, but have to put in a catheter, and some people prefer that. And there's a couple different other options, but it's a really big surgery to lose your bladder. Next. And then this is a picture of an ostomy and sort of the bag that they use to collect it. And so that's kind of the end of the intestine that you can see there on the right, and then a person putting a bag over. And so, you know, most people actually do really well with this compared to how they think they're going to do before surgery. But, you know, there's a lot of, you know, changes that happen, skin irritation, but also body image issues, intimacy issues that go along with having an ostomy. Next. And then advanced disease. So similar to prostate cancer, once the cancer has spread outside of the bladder or lymph node right around the bladder, it remains an incurable disease. And so historically, we have used chemotherapy as the cornerstone of treatment. And then finally, in the last 5 years, we've had some progress towards other treatments, and we'll talk about those, but things like 5 new immunotherapies, a targeted therapy, a new antibody drug conjugate, and we finally have some treatment options for these patients. And, you know, supportive care is really crucial, things like pain control for these patients. Next. And then lastly is kidney cancer. It's actually not quite last, but is kidney cancer, which is a cancer that develops anywhere in the kidney, but we really usually refer to it as, you know, kidney cells that are the ones that help filter the urine. Next. And there's actually several different types of kidney cancer. It's really not a single disease. And the most common we see is this type called clear cell, and you can see that on the left with a bunch of clear cells. But there's several different other types of kidney cancer that you can see. And next slide. And we think that these different types start from different places in the kidney, and that's why they look and act differently after diagnosis. So the clear cells we think develop from the blue part of the tube where you filter urine and so on and so forth. Next. So the most common type is this clear cell, and the tumors can get really big. You can see on the right, that's a really big tumor. And, you know, these tumors actually act different than a lot of other cancers, and they don't typically respond to chemotherapy, and that's because they lose this special gene called VHL. And this is actually a gene that you can inherit a loss from one of your parents, which can predispose to kidney cancer. But most cases of kidney cancer are what we call sporadic, meaning bad luck. Next. So these are the risk factors for kidney cancer. Again, smoking is on the list. Also high blood pressure, obesity, cystic disease, or some occupational exposures like asbestos or cadmium. Next. And the symptoms of kidney cancer, sometimes these tumors can get really, really big before they're diagnosed. You can get flank pain, blood in the urine, and an abdominal mass. You can also have scrotal swelling or swelling in your legs, or ascites, which is swelling in your belly. Commonly, these cancers jump to the lung, lymph nodes, bone, and unfortunately the brain. Next. And so treatment for kidney cancer is a little bit more simple actually than the other cancers. If you can cut it out, you cut it out. And we can cut out a lot. You know, we've had people with 14, 15 centimeter tumors in their cancer that are growing in their back, and the surgeons go in and cut it out, and that can cure them of their cancer. If it's metastatic or if it's spread to other places, we don't typically use standard chemotherapy, and so we use other types of therapy called immunotherapy or targeted therapy, which we'll talk about next. And so kidney, like bladder cancer, has had a huge explosion of different treatments, and this is just a timeline to see all the different things that have been approved since 2005, which before that we really had barely anything to treat kidney cancer, and now we have a lot of different drug options, including combinations most recently. Next. And so I just have one slide on testis cancer, testicular cancer. So most of these cancers are called germ cell tumors. So they start in the cells that make the sperm, and we see about 10,000 new cases per year. Typically this is in young men, so it's the most common cancer for men in their 20s, and is a very, very curable cancer. You know, typically we do surgery called an orchiectomy and remove the affected testicle. And then if it's spread to lymph nodes, people either get surgery, radiation, or chemotherapy, depending on the type and extent of the cancer, again, depending on the stage. Advanced disease, we treat with chemotherapy. And the good thing about this cancer is that chemotherapy is really successful. It cures these cancers. So it's very different than the other cancers we've talked about. You can have testicular cancer that's spread to all parts of your body, and we can give you 12 weeks of chemotherapy and cure you. Next. And lastly, just to talk about supportive care. So these things are really important, and perhaps even more important than some of our other treatments is supporting bone health, pain control, depression, treatment side effects, which you'll hear more about, and grief counseling. Next. And so the number of drugs that we have to treat these cancers is really skyrocketing, and you'll hear more about all the different categories in just a second. Next.
All right, so now we have our next question with using one of the different poll everywhere methods we talked about. And again, this is anonymous. What term refers to the extent of cancer in the body? A would be grade, B would be Gleason score, C would be stage, or D would be histology. And if you would take about 10 seconds to think about that and go ahead and put in your vote. Right, Dr. Rose, looks like we've got 100% saying that stage is the term. Is that correct?
That is correct. Yep, stage refers to the extent of cancer in the body.
Great, nice job, everyone. And then we've got another question, I believe. Which treatment is not an option in the management of localized prostate cancer? So which one of these? A, surgery, B, radiation, C, active surveillance, or D, immunotherapy? So again, which treatment is not an option in the management of localized prostate cancer? Take about 5 more seconds if you would, please. All right, and Dr. Rose, looks like they've settled on immunotherapy. How did they do there?
That is correct. So immunotherapy we do not use for localized prostate cancer, and we don't even use it very often for advanced prostate cancer either. So really the decisions are usually active surveillance, surgery, or radiation.
Great. Thanks to everyone for paying such close attention.
And this is just my email address in case anyone has questions or wants to reach out.
Great, great. And we will also make this recording available later, including as for attendance credit. Okay. So Dr. Rose, thank you so much. And Dr. Morgan, we're talking next about drug therapy and genitourinary GU cancers. Take it away.
Okay, thanks. So, one thing about drug therapy in GU oncology is that it's really exciting because not only do we get a lot of new drugs all the time, but as a pharmacist, I get to use, or we manage drugs that kind of span the entire spectrum of treatment for cancers. So next. So if we look at the classes of drugs that we use in GU, we use traditional chemotherapy, targeted therapy, immunotherapy, hormonal therapy, and then we also have some novel therapies that we use in prostate cancer that are not used in any other cancer. So I think we have the opportunity to use a lot of different of these medications. For me as a pharmacist, keeps me learning all the time and keeps me able to help patients with all these different types of therapies. So you can see I've listed kind of how we use them in difference. So traditional chemotherapy really use that prostate, testicular, bladder, which Dr. Rose has already mentioned. Targeted therapy we manage with kidney, we usually use in kidney and bladder, immunotherapy, kidney and bladder again, and then hormonal therapy and some of these novel agents we use in prostate. Next. So just starting off with traditional chemotherapy, I'll go through this pretty quick because I like to focus on some of our newer agents. There's different classes of traditional chemotherapy, alkylating agents, antimetabolites, antimicrobials, topoisomerase inhibitors, and some other typical chemotherapies. Next. So, and when we're thinking about traditional chemotherapy, we're really thinking about how the drug affects the cell cycle growth. So there's different phases of the cell cycle, and different chemotherapies affect certain part of that cell cycle. Next. So cell cycle non-specific agents that we think about really affect any phase of the cell cycle in any part of the replication process. So the toxic effects occur at any point of cell division. And these could be effective in bolus doses because, again, we don't need the cell to be in a certain part of the cell cycle for it to be effective. And a couple of examples are alkylating agents, anthracyclines, and platinum agents. Next. Cell cycle specific agents actually rely on the effect to be during cell division and not in an active resting phase. And oftentimes these medications can be delivered as longer infusions over several hours, or even continuous infusions or multiple infusions in the same day potentially, because we need to catch the cell in a specific part of that division phase for it to be effective. So some of those are antimetabolites, vincas, taxanes, and topoisomerase inhibitors. Next. And so again, I'm not going to spend a lot of time on this, but specific agents we use in GU cancers listed here. We use a variety of different traditional chemotherapy agents for the different cancers that we treat. So alkylating agents, we use a lot of cisplatin in testicular and bladder cancer. In bladder cancer, we also use a lot of gemcitabine. We use docetaxel and cabazitaxel often with prostate cancer. Etoposide we use a lot with testicular cancer. And then some other agents we use more rarely, but there are a couple regimens of doxorubicin and bleomycin. Okay. So, my focus and a focus of our clinic with patients on chemotherapy are some very common chemotherapy toxicities. So chemotherapy-induced nausea vomiting is a very common toxicity that we deal with in patients who are getting traditional chemotherapy, especially in our population, because we do use a lot of cisplatin, which is the most emetogenic chemotherapy. And so we have to manage patients with antiemetics pretty heavily. Myelosuppression is common, especially in our patients who are getting curative intent cancer, like our testicular cancer patients, and our muscle-invasive bladder cancer patients, because we're trying to get them through their cell cycles. Mucositis can be a toxicity that we manage often with these medications. And then, of course, we have to monitor for organ toxicity. So renal toxicity is very common in cisplatin, and that's something we spend a lot of time thinking about and managing in these patients, monitoring for liver toxicity, cardiotoxicity, as well as lung toxicity. So all of these things we're monitoring throughout their chemotherapy course and managing them along the way. Next. So, a lot of what I want to focus on today is targeted therapy, because we do use a lot of targeted therapy in a lot of different GU cancers. And so these are more newer generation of agents that are targeted at the cellular process instead of just kind of giving a drug that will kill any cell that's dividing. This is looking at specific targets in the cells that are causing the cancer cell to grow. And there's several different types of these. So monoclonal antibodies, antibody drug conjugates, tyrosine kinase inhibitors, and then other small molecule inhibitors. And we'll kind of go through what each of those kind of looks like. So monoclonal antibodies are a therapy that uses an antibody to target a certain receptor or target on a specific cancer cell. These are used across basically all cancers these days. These are the biologic agents that Dr. Rose had mentioned earlier in her presentation. And so depending on how much mouse protein is in each monoclonal antibody molecule is how kind of immunogenic the drug may be to the patient, so causing immune infusion reactions, and they're actually kind of labeled in each of their names by how much it is. So I like this nomenclature because you can kind of quickly assess how much mouse protein is in and potentially how much your patient may react during the infusion process. Next. So monoclonal antibodies work by a couple of different ways. They can either just kind of directly bind to a ligand on the surface of a cell and block ligand receptor activity, or inhibit dimerization, which then inhibits downstream signaling, which leads to apoptosis. You can also have some immune-mediated effects with antibody complement, activating the complement system and actually the immune system to help identify the tumor cell and get rid of that tumor cell. And some of the monoclonal antibodies can actually do both. They can activate the immune system as well as have a direct blockage of the cell signaling. So there's a lot of different varieties of monoclonal antibodies that we use today. Next. And then the antibody drug conjugate is just another level of kind of sophistication for targeting patients with monoclonal antibodies. So it's a monoclonal antibody that's actually linked to a chemotherapy agent. It's usually antimicrotubule agent. What happens is it binds to the cell surface antigen, as you would imagine an antibody would, and then it's internalized into the cell. And then when it's internalized, the linker that attaches the chemotherapy molecule to the antibody actually is degraded, and the chemotherapy is released inside of the cell. So it's a very targeted way to kind of deliver a traditional chemotherapy agent directly to a target that you're looking for. And we have an example of one of these that we use in GU oncology, which I'll mention, that we'll talk about in a second. Next. And then tyrosine kinase inhibitors are a small molecule that binds to, actually internally binds to tyrosine kinase and blocks cell signaling, downstream cell signaling. So basically, if we know a cell signal is upregulated, so in kidney cancer, we'll talk about VEGF inhibitors, and we can specifically block that downstream cell signaling, decreasing the cell's ability to divide, and it kind of sends that cell into apoptosis. And so that those molecules basically inhibit downstream signaling for cellular growth. Next. This slide is just an example of kind of what we'll be talking about in the next several minutes with targeted therapy. I'm not going to go through this whole thing. I just wanted to give you an idea of if you block one cell signal, you can block other processes that are use that cell signal, and that can lead to a lot of different side effects because of that, and off-target side effects. So when we're talking about cell signaling and inhibiting cell signaling, there's groups of side effects that come along with each kind of process that you're going to inhibit. And so I just want you guys to be aware that, you know, it's not as simple as blocking one signal and then you get the effect that you like. You also have a lot of off-target effects that can lead to side effects with these medications. Next. So some molecular targets in our GU oncology. For kidney, we typically target vascular endothelial growth factor and mTOR, or mammalian target of rapamycin. And then bladder, as Dr. Rose mentioned earlier, we have a couple of new targeted therapies that have just come out in the, I always say, I think now it's been almost a year that we have fibroblast growth factor receptor is a new target for bladder, as well as Nectin-4. Next. So VEGF inhibitors are common medications that we use in kidney cancer because, as Dr. Rose mentioned, VHL is upregulated, and that's involved in promoting VEGF and vascular growth. And so what we use a lot of these medications to target VEGF and to decrease cell signaling and not allow for more angiogenesis. And so we have a monoclonal antibody that targets VEGF, which is bevacizumab. We don't use this as much in kidney cancer these days, but I want you guys to be aware that there is a monoclonal antibody and a tyrosine kinase inhibitors that we that both target VEGF. So tyrosine kinase inhibitors, pazopanib, axitinib, sorafenib, sunitinib, cabozantinib, and lenvatinib are common medications that we use. And these are oral medications that we use to target VEGF in kidney cancer patients. And the big difference between the monoclonal antibody and tyrosine kinase inhibitors, monoclonal antibody, bevacizumab, actually binds to the ligand kind of floating around in your, at least this one, bevacizumab, and it does not allow that ligand to bind to that extracellular VEGF receptor. And then the tyrosine kinase inhibitors, as I mentioned earlier, kind of work intracellularly, inhibiting downstream signaling from from a ligand that's bound to the receptor. So that all leads to decreased proliferation and does not allow for angiogenesis. And so the kind of difference in mechanisms between those two. Next. And so as I mentioned before, if you're targeting VEGF, you're not only going to get decreased cell signaling for the kidney cancer cells, but also you're going to get it in other parts of the body. And so there's target side effects that we think of VEGF inhibition. One of the main side effects that can happen pretty quickly after starting the medication is hypertension. And then some other common ones are heart failure, impaired wound healing, proteinuria, bleeding complications, thrombosis, and GI proliferation. And so those are all kind of a class effect. So the VEGF, the monoclonal antibody, and the tyrosine kinase inhibitors kind of have the effects, those same effects. And then with monoclonal antibody, you can have infusion reactions, and the tyrosine kinase inhibitors kind of come along with a lot of other side effects, off-target effects because of the inhibition of the receptor. So diarrhea and hand-foot syndrome are pretty common across all of the those tyrosine kinase inhibitors that target VEGF. Pazopanib has a higher incidence of changes in liver function that we have to monitor very closely in the beginning. Sorafenib and sunitinib can affect the blood counts kind of more than others. A lot of our other ones can have effects on thyroid and changes, other kind of side effects that we need to monitor. And so this is what actually I spend a lot of my time managing in clinic, is these small molecule or tyrosine kinase inhibitor side effects, not only those target ones like hypertension, monitoring for bleeding and clotting complications and things like that, but also all of these other things like diarrhea, hand-foot syndrome, monitoring for liver function, and other kind of changes in patients' laboratory values. So we all work together to kind of manage these side effects. Next. And mTOR inhibitors are also commonly used in as second or third line therapy in renal cell carcinoma or kidney cancer. They decrease intracellular downstream signaling in the PI3K pathway, resulting in decreased protein synthesis and apoptosis. Everolimus is our oral mTOR inhibitor, again, commonly used second, third line monotherapy or in combination with a VEGF inhibitor. And the toxicities associated with this are mucositis, diarrhea, hyperlipidemia, hyperglycemia, and pneumonitis. So we do a lot of baseline laboratory monitoring for this, and again, supportive care with mucositis and diarrhea. Dexamethasone mouth rinse is recommended as prophylaxis for the mucositis, so that's something that we can recommend to help patients kind of avoid that side effect. Temsirolimus is our IV mTOR inhibitor. We don't use it that much anymore. It used to be favored in poor risk disease historically, but it's not a very common thing that we use now with all of our new medication, new kind of regimens that have come out in the past couple of years. And some toxicities associated with that are rash, anemia, nausea, peripheral edema, hyperlipidemia, and hyperglycemia. So some of the same side effects, but a little bit different because of oral versus IV. Next. So one of our newest targeted agents is an FGFR inhibitor, which is erdafitinib. It's actually first in class. Small molecule that was, again, FDA approved very recently. It does target gene mutations in FGFR and inhibits downstream signaling to lead to apoptosis and decreased tumor growth. There's about a 20% incidence of FGFR mutations in bladder cancer, so those are the patients we're using this medication in. And there is a very good response rate. So before this, and of course, the patients have to have this FGFR mutation and alteration. So we sequence the tumor and look and see if they have one of these mutations or alterations, and then they'd be eligible for this drug. And the response rate in those patients that are eligible for this medication is about 40%, versus previous kind of second, third line therapy, which would have been traditional chemotherapy, is about 9%. And so we've really, like Dr. Rose said, it's been exciting in bladder cancer because we've gotten some new medications on the market that have really helped response rates in these patients who have metastatic bladder cancer. And the toxicity associated with this are actually quite interesting. Again, you're blocking a lot of processes that are going on in the body by inhibiting FGFR. and which is fibroblast growth factor receptor. I think I mentioned that earlier, just wanted to reiterate what that meant. And so hyperphosphatemia is actually one of the most common side effects that we see with this medication. And actually we want to see that as well, because sometimes these small molecule or tyrosine kinase inhibitors have a side effect that can, if you have the side effect, it can indicate to us that you potentially could be responding. And so hyperphosphatemia for erdafitinib is that side effect that we hope to see, because it kind of correlates with response. Some of the other side effects are diarrhea, nail toxicity, some dry mouth, and then also ocular toxicity, which actually requires our patients to go to the eye doctor and get an exam monthly for the first 4 months they're on the medication. So again, that's something that I help coordinate, making sure patients are getting all of their follow-up and monitoring. Next. The other newer drug that we were using for metastatic bladder cancer is a Nectin-4 inhibitor, which is Enfortumab-vedotin. So this is our new antibody drug conjugate that we have on the market. Again, first in class drug, and right now it's only approved in bladder cancer. So Nectin is involved in polarity, proliferation, differentiation, and migration, epithelial, endothelial, and immune and nervous systems. There is a high expression on bladder cancer cells, but actually a low expression in normal tissue. So it is a really good target for patients with metastatic bladder cancer. Again, the Nectin-4 is going to be expressed on those bladder cancer cells, and it's going to bind to the bladder cancer cell and deliver that cytotoxic chemotherapy agent to the bladder cells. So that's why it's been a really good target for our bladder cancer patients. Again, we see very similar to our FGFR inhibitor, 40% response rates. The toxicity that we've seen, especially pretty significant toxicity, is rash, peripheral neuropathy, hyperglycemia, fatigue, diarrhea, nausea, and decreased appetite. So rash actually is interesting because Nectin-4 is expressed in the epithelial cells, as mentioned earlier. And so we have seen some patients get some pretty gnarly rashes since we started using this medication, requiring some inpatient admissions. So it is something to look out for, and again, something we work as a team to try to monitor and prevent from getting to that point. Next. And so immunotherapy is another common thing that we use, especially in bladder and kidney. Next. There are a couple of different kinds that we use. CTLA-4, PD-1, and PD-L1 are the most common. Next. CTLA-4 inhibitors actually kind of take the negative feedback loop off of the immune system at the level of the androgen presenting cell. And so that allows for the immune system just to be turned on and allows those cells to go out and find cancer cells. Next. And we also have PD-1 and PD-L1 inhibitors. They work a little bit differently in the tumor microenvironment, where the PD-1 and PD-L1 block the interaction between the T cell and the tumor cell and kind of turn the T cell off, not allowing it to recruit the immune system to the tumor cell. And so we have one works on the T cell side and one works on the tumor cell side. Next. And so the only thing that I'll say about these medications is it upregulates the immune system, and it kind of turns those checkpoints, as we call them, off, so that your body is allowing basically autoimmune kind of surge. And so you can have toxicity in any organ of your body, skin, GI tract, respiratory, endocrine. And so I basically just tell people if they feel any differently from the first day that they receive this medication, they need to let us know about their symptoms so we can kind of work through whether or not we think they're having a toxicity of these medications. And how we would typically treat those is with steroids. So we need to kind of turn off the immune system in order to let those organs that are being attacked by their body heal. Next. In the next couple minutes, I'm going to go over hormonal therapy for prostate cancer. So again, Dr. Rose mentioned that that this is the cornerstone for prostate cancer therapy, and it really is. So we have several different types of hormone-directed therapy to treat patients with prostate cancer, either localized or or metastatic, but mainly we use these in metastatic, especially the oral medications. So we have androgen deprivation therapy that's, again, used in localized and metastatic GnRH agonists and antagonists. We have a CYP17 inhibitor and then androgen receptor inhibitors. Next. So GnRH agonists and antagonists, how they work is basically to turn off the testosterone production from the testes. One works by, again, negative feedback, so you have an initial surge of testosterone that actually feeds back to the hypothalamus and tells it to kind of, it turns off the receptors in order for the cycle to discontinue. So then testosterone is typically not made. It takes a little bit longer than our alternative, which is the antagonist, about 14 to 30 days for patients to reach the level of testosterone that we like, which is less than 50. The antagonist just kind of blocks the receptor signaling at the level of the pituitary, and so then, of course, it's shut down. The pathway is shut down after that, and testosterone. The testosterone is no longer made, and that takes about a couple days. Next. And so we have a couple of different varieties, the GnRH agonists and antagonists. The advantage of the agonists is that they can be given every 3 to 6 months versus the antagonists. We would prefer the antagonists in patients who have high levels of disease burden to avoid any complications with the testosterone flare with the agonist. Next. Effects of androgen deprivation therapy are a lot. You can see here skeletal body composition, muscular strength, cardiovascular effects, sexual and other. And we work as a team to kind of manage all of these toxicities. Next. Abiraterone quickly inhibits the synthesis of testosterone and dihydrotestosterone by inhibition of a enzyme, which is 17-hydroxylase, and that decreases downstream production of testosterone and synthesis, which results in decreased testosterone production from the adrenal glands and actually the prostate cancer cells. Next. Importantly, it causes mineralocorticoid excess syndrome, which requires prednisone administration to reduce the risk of hypertension, hypokalemia, and edema. Also cause close monitoring of the liver, and then additional androgen deprivation adverse effects that we see. Next. Androgen receptor inhibitors, enzalutamide, apalutamide, darolutamide, they bind to the androgen receptor, inhibit translocation of the androgen receptor into the nucleus, and inhibits DNA binding. And they have some CNS side effects, so except for darolutamide, it crosses the blood-brain barrier. They can cause fatigue, dizziness, also can cause hot flashes and arthralgias. There is a risk of seizure highest with enzalutamide. Next. And I'll skip these two because I think we're running out of time, so we can just go to the questions.
Okay, so when treating a patient for kidney cancer, which therapy is most likely to cause hypertension? And that would be alkylating agents, A, VEGF inhibitors, B, Nectin-4 inhibitors, C, or FGFR inhibitors, D. And again, this is all anonymous. If you're not quite sure, go ahead and make a guess on that, and Dr. Morgan can let us know. Wait a few more seconds, and all right, thank you so much. So Dr. Morgan, how are they doing?
Yep, that's perfect. That is the correct answer.
Great. Thank you so much for answering that one. And the next one, the backbone of prostate cancer treatment is hormonal therapy. Which of the following hormonal target therapies inhibits testosterone synthesis? And would that be A, leuprolide, excuse me, B, you know what, Dr. Morgan, I'm going to let you pronounce these.
Okay, that's fine. A, leuprolide, B, degarelix, C, abiraterone acetate, or D, enzalutamide.
Thank you. I know you did that much better than I would have, so thanks.
No problem.
All right, so take about 5 more seconds again. All right. We're hearing enzalutamide. How did they do, Dr. Morgan?
Actually, abiraterone is the correct answer. Enzalutamide
Okay.
inhibits DNA binding, and abiraterone inhibits the synthesis.
All
I
right.
rushed through that a little bit, so I'm not.
Yeah.
We'll give them a break.
Sounds good. All right. And conclusion?
Yeah, so for my conclusions, drug therapy in GU spans many different classes of drugs. Each patient's therapy is individualized based on different factors. And as Dr. Rose mentioned, it takes a multidisciplinary team to develop a plan, implement the therapy, and monitor its side effects and effectiveness of these patients. So it's really important to have a big team to take care of everybody.
Great. So let's see at this point, and bear with me, I've got to go check on the questions in my poll interface, but let's go ahead and take a look. And this is your opportunity to share your questions with Dr. Rose and Dr. Morgan. While we're waiting to see what questions come in, Dr. Rose, let me start with you. Could you talk briefly about your trajectory to your current role and what made you interested in oncology and kind of what the in a few words the path was from that interest to your current position?
So I actually started out in high school working in an OB/GYN office, and I filed paperwork. Back then we used paper charts, and so every time something got written down, you needed a high school student to put it in the right folder. And then from there, I got an interest in sort of the careers of the people around me, and I became a nursing assistant. And so I worked as a nursing assistant in a nursing home for a while. And I really liked that work. It was very hands-on. And then I decided I wanted to go to medical school by the time I was, through my first year of college, and majored in biology, and then went straight into medical school from there. And I actually feel like it's a great path because I've seen a few of the different roles that are there and value them tremendously. Oncology was a little bit later of a decision. It was toward the middle of residency, which happens after med school. And I really like oncology. You see people at some of their most vulnerable moments and get to help them through it. And it's a real huge honor to be a part of that. The losses sometimes in oncology are hard, but the wins are that much better. And so I just really like getting to know my patients, working in the wonderful team that I work in where, everybody values the things that are really most important in life. And we all try to, get our patients to be able to enjoy the things that they want still. And I think it's a really rewarding profession. I'd never choose anything else.
Dr. Rose, thank you so much. And just a reminder to our audience that one of the reasons that we have this series is that we do hope to interest students and community college students, of course, in particular, in careers in oncology. So, I hope that's helpful to hear from Dr. Rose. Dr. Morgan, same question to you. What sparked your interest in oncology and how did you get to your current role?
Yeah, so actually I took a very unusual path. I was originally a communications major in undergrad, which I completed and thought I was going to go into sports public relations. My mom was actually a pharmacist, so that was kind of always in the back of my head. She said that I should just go to pharmacy school and forget whatever else I was interested in, which at the time I didn't want to do that. But I had some personal experiences with patients who people who had cancer, and so that kind of got me interested. I wasn't really sure what I wanted to do ultimately. I've always liked science. I don't know why I didn't do a science undergrad to begin with, but I didn't. So after that, I ended up just going back to school, getting all the science classes I wanted. I worked at the NIH as a pharmacy technician, actually. And then I applied for pharmacy school. I always thought from the reason why I wanted to go to pharmacy school was to get into oncology. I kept my mind open and broad in case I found something else that was more interesting. But I think not only did it pique my interest in the fact that I had some personal experiences, but from a pharmacist perspective, like I said, oncology is super exciting. We get new drugs, new mechanisms, new drugs, new therapies almost every couple of months. At least every 6 months we're learning about new medications and drugs that we're going to be using. And so that's exciting for me as like a science-oriented person. And then as Dr. Rose said, like taking care of the patients is such a great honor to be able to help them through the toughest times. And I think, we all serve a different role in that. And my role is helping with symptoms and supportive care and helping with side effects. And so I feel a lot of joy personally and able to help patients through that because they are going through a pretty rough time and some of the therapies are very hard to tolerate. And so being able to help them, somebody calls me and says they're extremely nauseous, can't eat, and then, give them a couple of things and then the next day they feel so much better. It's just really those things, those moments you're able to just at least help them through getting through the toughest time of their life.
Thank you so much, Dr. Morgan. Mm-hmm. And Dr. Morgan and Dr. Rose, we thank you both so much for bringing your gifts and talents and hard work to care for patients in North Carolina. So we will go ahead and wrap up there. I know we're a few minutes over time. I just want to remind anyone watching either this as a live session or as a recorded session later that this will be available in our learning portal and that students may go and watch this and then take a test at the end and receive a certificate of participation as well. We want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center and the University Cancer Research Fund. We want to thank specifically Mary King, Veneranda Obore, and John Powell for all the hard work they do for this and all of the many other lectures that are presented every year.